So I'm going to be talking today about some aspects of the changing face of autism and some of the challenges and opportunities that have to do with working with adolescents and adults. As always, I want to be politically correct and cite the various grants that support much of our work here, and also to point out a couple of publications, which is a handy way of also advertising one's books. I want to talk today about some challenges in terms of thinking about our understanding of autism, how outcome seems to be changing over time, and maybe a little bit about the economics of autism, and also how do we understand what's happened in terms of some of the changes, and finally, thinking about what can we do in terms of having a better job of translating research into practice. I want to thank a number of the associates, especially Debbie and Larry Hillebrand. I'll come back to them at the very end of the talk. They've actually funded a new fellowship program for a person interested in work with adolescents and adults with autism and related disabilities. I don't know if Roger is in the audience. Roger Joe is our first fellow, actually the Hillebrand Fellows, and that will be ongoing. We'll be starting a search for a person for next year as well. Also, the various foundations and granting agencies, publishers, and we'll talk about YouTube at the very end. So let me start with some caveats. As Mark Twain once said, I've seen a heap of trouble in my life, and most of it never came to pass. So I don't want to be too negative, but I also want to flag in the course of this talk some things are a little bit worrisome on the horizon. And as always, predicting the past is much easier than predicting the future, and the question of where we should try to go in terms of new directions in disabilities research is important. And finally, let me just remind you of that famous quote from Disraeli that there are three kinds of lies: damned lies, and statistics. And I'm going to show you a little bit of statistics, not too much, but take everything with a certain grain of salt. So some paradoxes and challenges. Autism was once thought to be rare, now it's thought to be very common. Dr. McPartland and I were just seeing a family debating the question. The mother was confused about, is it autism spectrum? Does it make any difference? And it's an interesting question as we've sort of had, I don't want to say diagnosis creep, but as people have started to think more broadly about autism and related conditions, it seems much more common. On the other hand, hardcore classical autism, which we'll say a little bit about, remains the sort of major prototype of the disorders in this group, and the one where most of the research, almost all of the research is done. People probably know that there was early confusion of autism. Was it a kind of schizophrenia? For many years, that was the only term that was available to describe children with autism, childhood schizophrenia, schizophrenic reaction of childhood. That only changed in 1980. So in that sense, autism as an official diagnosis has only been around for a short period of time. It's interesting, we're going to talk a lot about the research, to the extent that I can, about research with adolescents and adults. Keep in mind that probably 90+% of the research these days is on toddlers and infants. And so there are these funny disparities in terms of who is studied and who needs services. There's also some interesting diagnostic tensions, which we'll probably have a chance to come back to. And certainly if people ask me questions, we could talk a little about it. There's the tension recurrently of lumping and splitting. Autism spectrum, 5 disorders, 1 disorder. I'll say a little bit about that. Oh, and comorbidity. I'll say a little bit about comorbidity. That's the idea of having more than one thing. Autism plus depression, anxiety troubles, ADD. It's a very interesting and complicated area. Very quickly, to recap the checkered history of autism, Connor in 1943 gave the first definition. He said these were children who had autism. They were alone in the world. He talked about autistic aloneness in a very wonderful way. He also said they had trouble with dealing with the non-social aspects of the environment. What he ended up calling resistance to change or insistence on sameness covers, interestingly, a multitude of sins. But it's an interesting thing when you think about it, because he was contrasting the lack of social interest and, in a certain way, the over-engagement with the non-social world. The kind of troubles with change. It means the kid's really paying attention there, but not so much to the parents and other people. Michael Rudder is the next big person in the field. In 1978, came out with the first of something approaching an operational definition of autism. He said you had to have significant social problems, worse than you might expect given the person's overall cognitive ability, significant problems in communication and language, and these funny behaviors, the sort of so-called resistance to change, insistence on sameness, stereotype behaviors category, and you had to have it before age 3. DSM-3 in 1980 was the first to officially recognize autism. The definition in DSM-3 was very much the Michael Rudder definition. It was also the infantile autism definition. And by that I mean it was most applicable to very young children, and thus are most classical hardcore autism. DSM-3R veered in the other direction and actually opened up, to some extent, the floodgates in terms of the autism spectrum business, especially at overdiagnosed autism, apparently among the more severely cognitively challenged. The current system, DSM-4, and the international system, ICD-10, are the same. This was done on the basis of a large international field trial. It was actually centered here. There's autism in 4 other categories: Asperger's, Rett, CDD, and this funny PDD and OS category. We are looking at changes for DSM-5. We actually just had a talk about this last Friday in the autism group. The fundamental problem, DSM-5, it's a little bit, I have to be careful because this is going to be on the web. In some previous administrations, I'm not going to comment on the Obama administration, when people said something, they meant the opposite. So paradoxically, when you hear in DSM-5 the new definition of autism spectrum disorder, as far as one can tell, that means classical autism. There's not much spectrum about it. And in fact, one of the worries, and we may have a chance to talk about this, among the more cognitively able people, many of them will lose their diagnosis and possibly their eligibility for service, and that's actually a significant worry. Speaking, though, just briefly of research in autism, I want to make a couple of points. This is Leo Kanner, first paper in autism, 1943. This is from Medline. I emphasize you get different results depending on what you search, and also, of course, depending on what the keywords are. This is looking for either autistic disorder or autism as keywords. But here you can see in 5-year blocks the number of papers, and it starts going up and up and up. Here's DSM-3 kicking in, and we're starting to see a very significant increase. And here's the most recent numbers. This is now by year. So this is 2000, 2001, 2010, the last year I have data on, and you can see that in 2010 there were well over 1,800 peer-reviewed papers. Not chapters, not books, peer-reviewed papers on autism. So you can imagine this means you're going to have to read how many? 6 papers a day to keep up, which is almost impossible. Now the good news is there's so much more in terms of research. I don't necessarily say it's all of high quality, but it's actually surprisingly good. One of my other jobs as editor of the Journal of Autism is to manage a lot of this as it comes through, and every year we're up 5 to 10% in terms of the submissions, and every year our acceptance rate keeps going down. It's now less than a third. It's a happy problem to have. Let me point out that, again, with DSM-4, back here, you can see there's a steady increase. So the system has worked so far pretty well. Now, why has research increased? Well, intellectually, autism turns out to be a fascinating condition. We know more about the social brain. I'm going to allude to some of that. We also know for the first time we have the potential in a very truly meaningful way of bringing the brain and genes and behavior together for the first time, and it's really tremendously exciting. There also are social and political reasons. So we have support from parent groups, and we have foundations. When I first got into the business, people didn't know what the word autism was. Now you can't go on the radio and not hear about autism from Autism Speaks or from the Ad Council, which is, again, it's a major, major shift. We also have parents who have become much more vociferous. There's plenty of room over here for people. Parents have been willing to talk for the first time about the experience of having a child. They're willing to support other parents, which is fantastic. Unfortunately, one of the problems in the 70s was that parents were often stigmatized as a result of the work of Bettelheim and some other people. Parents were often blamed for causing their child's trouble, so it wasn't something people wanted to talk about. That's also changed for the better. Also, there are financial reasons, and I suspect most people in the room will know Willie Sutton. People know Willie Sutton, a famous bank robber. They once asked Willie why he robbed banks, and he said, because that's where the money is. And in this day and age where NIH resources are decreasing, happy news for the autism folks, this is still where the money is. As Tom Insel says, it's autism all the time and at NIH. And it's true, there's a lot of interest at the federal level. I'll show you a slide on that in a second. More media attention, and also a lot of stuff on the internet. Anybody take a guess, and I can't tell you today, but I can tell you a month ago, if you type autism into Google, how many hits do you get? 17 million. Now, what you're supposed to do with that, I don't know. And we'll come back to talk, it's a problem. Because the good news about the internet is it's free and openly available, it's very convenient. The bad news is it's not policed. Here is a slide, and this is from the Congress, actually. It's the Congress's numbers, and that's why it stops in these odd times. But this is from the General Accounting Office, and it shows federal activities in autism from 2000 to 2005. And you can see they're getting up to $100 million, and it's even more now. This has, again, been very good news in terms of stimulating research and work in the area. At the same time, it's interesting. There are some challenges. The grant review process, people will know, especially if they've either been the recipient of a grant review or even more interestingly, been on a grant review committee. The system is not perfect. You basically have to have pilot data to show that you can do the work, to get the money to do the work, if you can follow that. So you have to have kind of done the study before you can get the money to do the study. There also is a big impact of fads and sort of the local interest of the moment, and that is an important problem. There are some real challenges for treatment research. Treatment research is some of the most difficult to get funded. I sometimes say treatment research is a little like an oriental carpet. A good oriental carpet, there will always be something wrong with it because you don't want to offend God. And the same thing with treatment research. There's always, you can find something wrong. And all it takes is one person to put the knock at a federal level at a grant review on a grant, and it's dead. So that's a problem. So the treatment intervention research, as I'm going to show you in just a second, has stayed relatively flat in the face of this otherwise amazing increase in research. Also hard to get access to relevant groups. Some of the kinds of research we might like to do are somewhat limited, given the nature of autism, the associations with developmental disabilities, the issues of informed consent, that whole package of things. And finally, I think in this country, there's been a lack of emphasis on translational research. When you review grants for the Wellcome Trust or the Brits, there's a little section in the grant that asks the researcher to say, tell us, how are you going to translate this into something that's going to be useful to parents and schools and to the lay public? And I think that's actually a nice feature that we have not perhaps emphasized as much. This is especially true when we talk about older children, adolescents, and adults. And this slide just shows you the relative lack of growth in treatment studies. So this is the gray bars, or the upsurge in autism research reports, but these are the ones that are treatment. So you can see it has not kept pace in general. There's more than there used to be, but still not nearly as much, and much of this is inflated by single case studies. Economic issues. Autism is a costly problem. Gans up in Boston has estimated that back in 2006 in the US, it was typically at that point costing about $3.2 million for a person over the course of their lifetime. He thought we were spending about $35 billion annually in this country on autism. Martin Knapp in the UK, another economist, estimated that they were spending about 25 billion pounds a year. So this is a costly problem. Increasing functional outcome has important economic as well as social policy and ethical implications. So the happy news is if we can convince the policymakers this is something to put money in, there's a good payoff, literally. So let me, in some funny way, start with the end of the talk and then we'll recap. Outcome in autism. There's an excellent review by Pat Hallen in 2005 in the Handbook of Autism. She points out that there are many differences in terms of people doing outcome studies. There's differences in methods, difference in terms of criteria used. In general, however, the trend has been towards better adult outcome. More individuals with autism are talking. More have higher levels of cognitive ability, more are employed. There still is the recurrent problem of what it means to be quote-unquote normal or cured of autism. Over all the years I've seen, somewhere between probably 7,000 and 10,000 patients. I've maybe seen 4 or 5 that I would say on meeting them I didn't realize they had autism as adults. It's not impossible, but it's relatively rare. More typically, you see people with social oddities, other kinds of issues, and I'm not knocking that. But people sometimes will want to say, oh, this kid's cured, or he's quote-unquote normal, and there is a broad range of normal. But it's an interesting dilemma, but there's no question that outcome in general is getting better. So there are some issues in terms of thinking about looking at the outcome research. That early confusion about autism and schizophrenia was a problem. There have been some changes in criteria back with DSM-IV. There was an attempt to make the criteria more neutral to IQ, so that it would pick up fewer of the lower functioning and more of the more able people. That was actually a very explicit stated goal of the process, that we wanted to be IQ neutral as a system. And the stringency of definition obviously has a lot of bearing. Loosey-goosey is going to be one thing, hardcore classical autism another. Also, some very important changes in intervention. In this country, Public Law 94-142, what now is called IDEA, for the first time mandated schools to provide services to children with handicaps. This was a watershed event in this country. Similar things happened in other countries, like in England, but this made a major, major difference. Up to that point, schools could and often did say to parents of young children with autism, we can't educate this child, put them away somewhere. And that happened. People ended up at state training schools, Mansfield, places like that, where they learned to live in institutions. And as time went on, people realized that was not such a happy thing, and it was actually separating kids from their families. It was preventing optimal growth and outcome. And with Public Law 94-142, for the first time, schools were mandated to provide a free and appropriate education. The other things have had to do with important changes in early detection. We were just talking this morning, we had 3 cases in the autism clinic. We always have 1 case under 3, and today I guess we had 2 cases under 3. We've seen not infrequently children under a year. That's a major change from even 10 years ago. And 20 years ago, seeing a 4-year-old was a young child with autism. And methodological issues, there's a lot of different approaches people have taken to quantitating outcome. The happy news is that Pat Hallen has done a good job of summarizing this. So she has 3 categories, and good, fair, and poor. Good means moderate to high levels of independence, self-sufficiency as adults, with some friends and acquaintances. Fair means needs some support at work or home, but some degree of autonomy, so some degree of personal independence and self-sufficiency. Poor means living in situations where there's essentially 24/7 observation. So it's more residential settings. And again, I emphasize this normalcy business is a bit of a red herring. If anybody's interested, we can talk more about it. So I am going to cherry pick studies. I'm going to tell you why in a second. I am cherry picking the first studies from 56 to 74. These are again summarized by Pat Hallen. Here's good, fair, and poor outcome. And you can see that in these studies, the first one is actually by Lee O'Connor and Leon Eisenberg, and going up to 74, and I'll tell you why we stop in 74 in a second. But you can see that on average, the good outcome, meaning adult independent self-sufficient, maybe averaging 5-6%. Most people ending up 2/3 in institutional settings as adults. And now I'm cherry picking from a different cohort, 89 to 2003. Now look what's happened with the good. We're averaging about 25%, and there's good reason to think this number is continuing to change for the better. This is great. Now why am I cherry picking these funny years? So I'm cherry picking the first studies that were done before Public Law 94-142 kicked in, before service was mandated, and then I'm cherry picking after Public Law 94-142, but before DSM-4, which might have introduced artificial changes in outcome. But you get a sense that there seems to be something really, truly going on here. Now, why is this? Well, it seems to be several things. We do think that earlier diagnosis and intervention makes a big difference and leads to much better outcome as a group. The problem for the individual child, as Jamie and Rhea and Michelle and I were talking this morning with the family, the individual child is hard to predict, but as groups, we can do a better job, and as a group, kids are doing better with intervention. There is some contribution probably of the broader diagnostic practice to this, but it's probably relatively small. And we do think that there are more and better supports and intervention tools. There's technology. We could talk to the family today about a technology tool, iPrompts, which you can download to your iPad or your iPhone, and it's a great little handy thing for kids on the autism spectrum. Now again, issues. Not every child gets better. Even kids that we're sometimes optimistic about in good programs, for reasons we don't always understand, don't always do well. There are always issues of matching children to treatments. It would be typically the case that a school has an autism program, they will have their program. It may be a TEACH model program, it might be a Denver model program, it might be an ABA program. The problem is, what if you have a child who might not do so well with that particular kind of program, but would do better with another one? So that's a funny problem. And there has been a dearth of studies on older individuals. For anyone interested in treatment, there's a wonderful book called Educating Children with Autism from the National Research Council. It focuses on young children. It came out about 10 years ago now. It was really a landmark in the field. Kathy Lord was the chairperson of a committee I was on, Sally Rogers, Sandy Harris, a bunch of folks, and we looked at all the data looking at outcome and autism and early diagnosis. This was prompted by a question from the United States Department of Education: does intervention make a difference? To which the short answer is yes, it makes a big difference. The kinds of intervention programs, I think we looked at 10 programs around the country. Structured intensive intervention, they have many commonalities and a few differences. Again, we emphasize not every child gets better, but as a group there appeared to be improving outcome looking at any number of metrics, and early and sustained intervention was really important. Also, we talked about the early efforts with major tranquilizers. There's been some work subsequently, and we actually now have some drugs that have been approved specifically for the treatment of autism. So what's our understanding of the model of autism? What's the trouble? We were talking about this with the family just this morning. Autism, I'm going to show you more in a second, is a disorder that profoundly impacts social interaction and social information processing. If you have problems in interpreting social information, if the social world is not so relevant to you, you're not such a good learner. And that's a sad reality. So the trouble we know is that autism has an interfering aspect on development. We can actually quantitate now from some of the studies I'll show you in a second, probably about 90% of the social affective information and ongoing interaction is lost to the child with classical autism. It's like they have blinders on, so they're getting only a small fraction of what's really going through. On the other hand, the bit of good news here, development happens. Kids with autism grow and change and they can learn. So the strategery, as our former president would say, is this. We want to minimize the negative impact autism has on learning and maximize as much as we can the tendencies towards normal and normative developmental processes. And that's it in a nutshell. And it's like the golden rule of autism intervention. If you can take that away from this talk, that's an important thing to take away. That really this is the goal of treatment, and this is what we are trying to do. Now, what do we understand about the social brain and autism? And we have a body of work on this. Kevin, I'm sure, is going to be talking about this later in the year. This is a study from some years ago that was done here. Bob Schultz was the first author. This was a study looking at more able people, looking at faces and the fusiform gyrus. This study has now been replicated well over 10 times. And the bottom line, folks with autism and Asperger's, bright people, didn't seem to use the part of the brain, the fusiform face area, that the rest of us use for looking at faces. They used it when they actually looked at their favorite objects, but they didn't use it for faces, which is interesting. So in a sense, it's as if they see faces like they see other objects. They're not special in the world. And people probably know that some of our work, the early work on eye tracking, which was done with adults, we found, to our surprise, very significant differences in the way people with autism look at social scenes. So this is about 5-10 seconds of the movie Who's Afraid of Virginia Woolf, and this is done with a little tiny infrared camera, which is invisible. We can track to see exactly where the person's looking. The typical person turns out to go back and forth between the eyes of the speaker. A very bright and successful man with autism, it turns out, to our surprise, goes back and forth at the mouth. He tracks the mouth very exclusively, and this is an example when I talk about the kind of information that's lost. So in this scene from the movie, this is just a couple of still frames, the young couple is talking with Liz and Dick, and George Siegel, the young man, is talking. His wife has had a couple of drinks too many. I'm sure this would never happen at Yale. This is some other New England college. And she starts to show her speech, and she starts to embarrass her husband. So this is the interesting thing. The typical viewer starts with George Siegel's eyes. Sandy Dennis starts to speak, switches to her, but then looks at the husband who's not talking, registers the fact the husband's embarrassed. Back to her, back to the husband, back to her, back to the husband, back and forth, sample, sample, sample. The person with autism, once she's up and running, moves from his mouth to her mouth, never looks at the husband, would never know. And this turns out to be a surprisingly very significant difference. If you look at where people are looking, these are, again, very bright people with autism. This is looking at eyes in these few clips of this very social movie, this very intense social movie, and you can see there's no overlap of the distribution. That it's a very different movie for the people with autism, and these are very bright people with autism. And if you quantitate this by turning it into an effect size, the effect size there is 3 point something. This is a whopping effect size. This is like a Z-score. So this is an enormous effect. Keep in mind, in terms of our work, sadly, with social skills interventions, I think the meta-analysis say the effect size is something like 0.4. So it's like we're really pushing against the tide with this, but this is kind of what we're trying to cope with. And I know there's a strong analytic presence at the Child Study Center, so I want to throw this in, which is this wonderful scene in the movie where Liz Taylor is making whoopee with a young man in front of her husband. And this is the first concrete proof of the Oedipus complex. The typical viewer is going zoom, 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 but looking at the husband who's not talking. So looking at Liz, looking at George, looking at the husband, Liz, did you see that lovely Oedipal triangle? The person with autism starts at his mouth. You think it looking at her nether regions, but in fact it's a little misleading because her head's moving. But it goes back and forth to the mouth, never looks at the husband. So what are the challenges as we think about adolescents and young adults? Well, first of all, adolescence can be a challenge for everybody. There are lots of issues in terms of medical care. Unfortunately, one of the problems, and this becomes true even for the more cognitively able, parents and kids try to avoid things that are going to cause trouble. Doctors cause trouble. Going to the doctor, going to the dentist, even worse. And so these things unfortunately tend to aggregate. On top of that, we give medications which slow the person down. Often these are people who are not really engaged in sports and other kinds of physical activities. Obesity is a problem. One of the few things a kid will do to be happy is to sit and eat the corn chips in front of the television. And that causes its own sets of issues and trouble. We have behavioral and psychiatric interventions, obviously, but these get somewhat more challenging as kids get older, and as our colleagues in adult psychiatry aren't quite necessarily knowledgeable about what to do about them. We have a lot of supports that we can kick in terms of teaching adaptive skills. We can teach social skills and communication. But again, you have to know what you're doing to put those into place. There's challenges in terms of the transition into puberty for both boys and girls, and then into adulthood. Real significant problems around insurance, medical care reimbursement issues, and social and vocational supports. This often is an area where with a little bit of help, the person can be helped in a major way in terms of the difference it makes for their life. But the trouble is getting that little bit of help. In some states like ours, it very much is focused on IQ. So in this state, along with Alabama and Mississippi, if you don't have an IQ in the mentally retarded, intellectually disabled range, forget it in terms of services, essentially. There's some experimentation now to try to work on that. And it's a shame because this, the sort of next step of the population are the people who could be helped to become much, much more functional. Again, adolescence, puberty happens because of biology, not because of diagnosis. Often, and Connor pointed this out, behavior problems increase in adolescence, often about a year or so before they start to see the signs in terms of hair and body growth. There are issues of sexuality that can be very rate limiting for adults. There can be many challenges relative to peers. The problems in social communication, so-called pragmatic language, become more and more and more problematic. I can give you some examples. So for example, we have a man who works for us who's on the spectrum and who does copying. The first time I gave this person something to copy, there was a little yellow paper on top, and I said, Joe, which is not his real name, Joe, could you make 3 copies, Fred? And I come in the next morning and he's written yes on the paper. Are there 3 copies? No. Because he could. Yeah, he could. But actually the fact that you laugh, I want to point out something that's interesting. He didn't intend it to be funny. This is where his life is lived. So you can imagine a high school student who's doing this all the time and people are laughing at him or her. And they're not intending to be funny, but people are laughing anyway. And you can understand why. Sometimes when I'm talking to mixed groups of parents and teachers and I can tell stories like this, I'll say, I'm going to tell you a story and I can predict who's going to laugh and who won't. The parents won't because they live with it, they know it. And it extends into all kinds of other things, figurative language. The phrase, kiss my butt, you can imagine. That can cause a lot of trouble if you're very literal. We had one young man who liked to comment on ladies' breasts. This turns out it's one thing when you're a 4-year-old, it's another thing when you're a 15-year-old. And fortunately, he was able to transform this with some effort and help into commenting on ladies' breathing capacities. So it was still weird, but it was much less likely the police were going to be called if he said somebody had a nice pair of lungs, right? So it's that kind of stuff. And again, parents, sadly, live with this every day. Transition issues get to be a real problem. We mandate transition planning in schools. We don't always do such a great job, I would say, unfortunately. And again, the outcome studies, interestingly, starting with Connor, suggest that for reasons we don't totally understand, some people in adolescence take off. Other people go the other way. Some of the examples, there's one man who I know who's wrote his autobiography some years ago that was published in the Journal of autism. He was actually shown at Grand Rounds, Sally Province, in the 1950s. It's an example of Connor's autism. Didn't talk until he was 4.5. He was actually in the nursery school here. When he started to talk, he started talking in full sentences about something that happened the previous year. And in adolescence, he had been kind of marginal. In adolescence, he wanted to fit in. He ended up going to a trade school, and he does welding on submarines. And it's a perfect job for him. It's very repetitive. He's very meticulous. He does the same thing over and over and over again. Fantastic. So, medical issues. We do know that seizures are more frequent in autism, and they sometimes have their onset in adolescence. I'm going to show you a slide in a second on that. Accidents, injuries, and safety issues also become problematic. I can sadly tell you chapter and verse about many people, things like the child jumps out of the car on the turnpike, the child who jumps in front of the freight train that's pulling into the station. Drowning accidents are the leading cause of death in autism, and that's true for all ages. The symptoms of autism do pose challenges for the healthcare system. These are folks who are, again, they're limited in terms of their activity, they have poor prayer problems, they tend to be obese. The medications we use often, unfortunately, can be associated with obesity. All of these are signs of trouble. And seizures in autism, the light green bars here show onset of seizures, recurrent seizures, epilepsy, not just a febrile seizure. Recurrent seizures in the green bars, Cooper, 5,000 British children. This is from the British Public Health Service. And this is age in years. Obviously, once you develop seizures for the first time, you can't develop again for the first time, so you drop out. Less than 3, 3 to 6, 7 to 10, and so on. That's the normative sample. By the time you're 15 to 18, less than 1 in 1,000 kids develop seizures for the first time. In the typical population, the normative population. This is a sample from New Haven of 400 and some children. This was a medical student thesis. And this is another large sample from Boston. And these are studies that were now done about 10, 15 years ago that remain actually the largest studies ever done on this topic. But you could see a peak of onset early in life, but another one in adolescence. There's a lady I take care of at a local group home who in her 50s had her first seizure. And I got a call from the Dartmouth ER, and we had a discussion about seizures and autism, and I talked to the ER doctor about this, and he said, well, and we agreed we wouldn't have to necessarily treat it, we would see what would happen. She's not driving heavy machinery, et cetera. And then he said to me something like, this is back to the challenges of the healthcare system, well, as soon as she starts talking again, we'll let her go. And I said, well, I've known the lady for 20 years, and she's never said a word to me. And again, the medical system doesn't always kind of quite know what they're dealing with, unfortunately. The seizures, by the way, of all kinds, most commonly major motor. Insurance coverage is a problem. Often choices are limited. Healthcare reform and the new mandates, we still don't know how that's all going to play out. One of the worries sometimes when you mandate universal coverage, it means minimal coverage for everybody, but it's universal. So we'll have to, it's a tricky business. We'll probably have a chance to talk about this later on in several contexts during the year. The transition from pediatrician to adult-based care can be a big challenge. Family doctors can sometimes be more engaged around these issues, but it can be a problem. I've had internists call me to say a 20-year-old wouldn't let them look in their ear. And so it's more like a pediatric problem than an adult problem. Psychiatric care issues, and again, the tensions around adult and child psychiatry. People sometimes think if we're child psychiatrists, we only see children. I'm always explaining to people, no, it's different than pediatrics and internal medicine. All child psychiatrists are, by definition, adult psychiatrists as well. And clearly, we need new models of care. We need a better system, and we could come up with, I think, very interesting models, thinking, for example, using nurse practitioners, people who have special training that could be really minimal training, but could really be very instrumental in helping large groups of children. I mentioned often there's an upsurge of behavioral difficulties shortly before puberty. It's always hard to know what to make of this. People speculate about raging hormones, but they speculate about that in the general population as well. But it's a very common experience of parents, not always. And often, fortunately, it tends to, quote unquote, burn out after a year or two. The problem that when we get into with this is a very complicated problem that comes up actually in a couple of respects. The first is the problem of so-called comorbidity, having more than one thing. This is a dilemma. In the international classification of diseases, the tendency in general is to favor a single diagnosis. It's to favor parsimony. You give autism, that's it. In DSM, it's a little more the thousand flowers blooming approach. In autism, the child we saw today had a diagnosis of autism and, was it receptive expressive language disorder? Okay, that makes a lot of sense. And you could throw in others, and you could throw in ADD. A child did have attentional issues, and the child, I'm sure, was anxious. And then the problem is, which is, I mean, it's okay as long as it's a convention, you understand it. The difficulty is when people start taking it seriously and follow up each diagnosis with a medication. The record number of medications I've seen a child with autism on is 14. How in the world you could disentangle what 14 medications are doing, I do not know. Paradoxically, the other problem here is what's called, is the reverse of this coin, diagnostic overshadowing. This came to our awareness in the intellectual disabilities world some years ago. People for years and years and years sort of presumed that having intellectual disability or mental retardation kind of meant that was it. All she wrote, that's the only problem. Well, when you think about it, having a disability is only going to make you more likely to have other troubles, right? It's not going to protect you. It's not like getting a flu shot. And in fact, when people then took things like the DISC and sort of the standard diagnostic interviews and gave them to people with mild levels of cognitive impairment, IQ 55 to 70 roughly, their rates of psychiatric difficulties are 4 to 5-fold increased over the general population, which makes good sense. And it's not just every kind of difficulty, it's certain kinds of difficulties. Depression, anxiety, mood problems, attentional issues. So it's an interesting, paradox, the sort of what's the best approach to this, and there's no single simple answer. Another problem, of course, is many of our patients have very limited and/or idiosyncratic language. They have communication problems. And a real problem actually throughout age, but into adults and adolescents, is the lack of integration of treatment providers. The speech pathologist could be working quite independently of the psychologist doing the social skills intervention, could be working quite independently of the psychiatrist who's giving medications for the attentional problems. That's another challenge for the system that unfortunately, sometimes with good school districts that can be largely dealt with, but as kids get out of school districts, having the parents or the child, the young adult, take responsibility of that can be an issue. We do now have some limited number of medications that are officially FDA approved. These treat the so-called resistance to change, that sort of third category of behaviors, the agitation, the difficulties with the stereotype mannerisms. So far, we don't have medicines for the core social difficulty of autism. There's some hope in this regard, but not quite there yet, but we're working in that direction. There is some suggestion of differences both in terms of response to medications before and after puberty. The SSRI medications, which are very commonly used in this population, as far as one can tell, looking at the meta-analyses, before puberty don't really work quite so well in children. There was a wonderful study that, I don't know if Larry's in the audience or not, Larry Scahill was one of the authors of with the RUP group that made that point. Sometimes the side effects can be very problematic. I mentioned the obesity with risperidone, which otherwise can be very effective. It can be a major challenge. And the research, of course, is somewhat limited. One of the difficulties with the research is, this is one of the funny tensions around our tendency to have evidence-based treatments. You can have such pure research groups that they're not representative of the real world. So if you have a child with autism, you want to look at, well, he can't have X, Y, and Z, and he can't be on medications, he can't have seizures. The next thing you know, you're studying a very small group of children. Risperidone, I've mentioned, this was the study that was done actually in part here. I was the first PI, and then Larry took over for this RUP network that was based here and several other sites around the country. This was collaborative, a multi-site study. It was double-blind, placebo-controlled. We found differences in 2 weeks after medication of the active agent. The issues had to do with weight gain, but it's illustrative of the kinds of things we could do if we got our act together and did this in a more efficient way. One of the interesting examples of this was a federally funded study. It was basically imposed by the feds. It didn't quite go through the usual peer review process. This was actually funded after a whole network had gotten done, and the fed said, okay, we want you to work on this one study together. And that was kind of how the system worked, and that's good. But that's the kind of thing you need to do if we're going to increase work in this area. The kinds of areas we work on in terms of intervention, everything. Adaptive skills, communication, social, sexuality, mental health issues, legal issues, vocational, living arrangement, and I'll say a word about college. Adaptive is real life skills. This is the Vineland. What we want to know is not whether the person can do math equations in their head. Can they walk into McDonald's, get a cheeseburger and change, and walk out again? And we have, sadly, examples of kids where they are always doing math equations in their head who cannot possibly deal with McDonald's. And so this, again, is an important part of where life is lived. Again, one of the tendencies in autism is a kind of a gestalt learning style. People learn things in a whole chunk, and they don't like change, and they have very rigid. And that turns out to be a real problem when you want to generalize skills. And it becomes really important, also becomes exemplified around things like driving. Driving is a big issue. If you don't drive in this country, you're in deep trouble, except if you live in very urban areas. Fortunately, there are a few approaches to this. It's a whole other interesting topic. There's a local man here in Connecticut, also with an outlet in Florida, who's a special needs driving instructor. And if he takes you on, he will stick with you till you get a license, no matter how long it takes. He doesn't take everybody on. He's a special educator who also has training in the area of autism. He's a wonderful guy to work with. This turns out to be a very interesting thing. The man that I mentioned I did our first eye tracking studies with Virginia Woolf, the movie, he's a man who drives, but he does not drive on the turnpike. He can't cope with that. And that's fine, but he can drive otherwise. Again, that's wonderful. Communication skills. There's a correct perception that most of the absolute progress happens in the first 5 years of life, but even nonverbal adults can be helped to be more communicative. We were showing a family today eye prompts, which is something that's nonverbal. It can just live on your iPad or your iPhone. It's something that can really help people become more communicative and organized, even if they don't have language. That's a high-tech solution. There's also low-tech solutions. Pictures, picture exchange, schedules. The group home that I consult to with adults, about probably 2/3 of whom are totally nonverbal. Everybody has a bulletin board that shows their schedule for the week. As they finish activities, they turn pictures over so they can see what's coming next. Very adaptive. Social skills. There are all kinds of approaches to teaching social skills. These include using peers, especially with preschoolers, hybrid methods where we combine kids, for example, in social skills group, and adult instruction. Most of the research has been done with younger children. We've had a track record here in town. Nancy Moss for years, Kathy Koenig here has written a lovely book on social skills. The trouble is, much of the research with older individuals is quite limited. It's very top-heavy in the preschoolers, some in school age, and then very little by the time you get to be adults. And the social skills gap, as we talked about, is tremendous and important. Social skills are the most important thing in terms of the definition. We know that social change happens over time, but the social deficits have a major impact on learning. If you think about the child who fails to attend to adults, having that child go to the first grade, sit in a little stool or a chair, pay attention to a teacher, focus on what she's saying or he's saying, that's a tremendous social burden. And the amazing thing is that most kids can do it. And so you can imagine if you're a child with autism where the world is equally irrelevant, the ceiling is more interesting in the floor than the teacher, that's going to be a problem for learning. And so the social things are really very important, and also the social things are very important in terms of generalization. So if you've got a social vulnerability, you're going to have challenges for learning, and you're going to have challenges for generalization. We've talked about some of the advances in gaze research. We know more and more. Again, most of this work has been done with younger children, but now we're at the point of thinking about new animal models. There's some very interesting stuff going on here, both in Paul Ambrose's lab, but also Flora's, and now with Hannah, that we're really thinking in new ways about bridging the gap between what we know in terms of the genes and the brain and the behavior. One of the problems, again, I would emphasize is we have not perhaps done such a great job of translating what we do know from research into the world of schools and families. Social skills teaching is more of a focus. We do need better research on this. We need support for people at all levels. Paradoxically, adults can use a lot of social skills intervention and support. They're the hardest group to find social skills and intervention support for. And I think it's interesting to think about most of the work done with adults is adult work with adults. It's not peer groups, and it's not, because the peers, it's like they're left in the dust by the time they get to high school. And so it's adults, and it's very explicit and it's very concrete. And it can be very helpful. We were talking this morning in the autism clinic about this. It doesn't have to be and shouldn't be sort of play-based psychotherapy in the sense of waiting for the child to elaborate a theme and a fantasy. It's much more concrete about what you do and don't say. These are the rules. Rule 101, you don't talk to ladies about their breasts in public. Let's write that down. Or let's role play how we're going to do, but really and it can be tremendously helpful. It's more of a life coaching model than an intensive psychotherapy model. But the problem is you've got to know what you're trying to teach. But it can be tremendously effective, and really the patients can be wonderfully rewarding to work with. We also think there's probably a good potential for metrifying in some funny way some of our understanding about the social skills deficits to things like eye tracking, looking at new measures. Fred Schick is working along with Brian and Adam Naples on some ways to actually take our eye tracking gizmos out into homes and schools. We're actually doing a project with the British Art Museum to see what people look at when they're looking at pictures. Sexuality issues, this is complicated. As you can imagine, it's complicated for everybody, even worse if you've got a disability. People have more sexual interest. People have often the intense social feelings of one kind or another. There's all kinds of stuff in terms of basic awareness, privacy issues, what you can and can't talk about, who you can talk about it with, what can and can't be done and where it can be done. It may be okay to masturbate in your bedroom, but not in the living room. Stuff like that, which sounds kind of simple, in fact is very complicated and sensitive. One of the further complexities for the adolescents and young adults, especially for the adolescents, is these are mostly boys who are being taught by women, which is complicated. So this is a very interesting area. There are some good resources available actually for the whole gamut, ranging from very low functioning to much more able people. And they're published curricula, guidelines, there's videos, there's all kinds of stuff. But again, for parents to know that this is out there and to be able to tap into it. We do need better models for mental health service, again with this life coaching model and the long haul. We can be more proactive. You can do homework. You can do role play. You can be very involved. The insurance reimbursement remains a problem. Even with the passage of Obamacare and parity, we have troubles getting services. There aren't so many providers, and often the level of service is not nearly what we would like. Legal issues come up in very interesting ways. For the more able students, our kids with Asperger's who talk a lot but have a social disability, paradoxically, often it's because they're rule governed that they get in trouble with the law. The classic example a few years ago was a young adult, late adolescent, who saw a girl in the grocery store. And he knew this girl from school, and he wanted to say hello. Now, we had talked about how you say hello to a girl, right? But he had never done this in a grocery store. So that was already a challenge, right? And he's got 3 pickup lines, right? Well, none of these, he can't figure it out because it's a grocery store. It's not his usual place. So he's muttering under his breath. He's rehearsing, which he does, and which actually is adaptive for him. He's rehearsing what he's going to say. So this girl who vaguely knows that he's aware of his existence, she sees this guy coming up behind her, and he's getting closer, and he's muttering. And she's getting nervous, right? And she's getting more and more nervous. And again, I'm very sympathetic. I'm the father of 2 young women. And so she wants to go to someplace where it's safe. So she rushes to the express line, which is the closest line where there's an adult. And it says 10 items or less, but she's got more than 10 items in her cart. And he's really worried about she's going to get into trouble. So what happens? He starts to take stuff out of her cart. So it's things paradoxically like that. Or the light changes and it says don't walk, and the kid stops. And the traffic is beeping. I mean, I've literally seen patients hauled into the ER because they thought they were suicidal because they stopped when the light said, don't walk. So it's an interesting, very interesting, and you can never anticipate. And that's the amazing thing. When you work with somebody, I'm always stunned by the things that people don't know that the rest of us just assume. Meltdown and aggression and communication problems are real issues for the less cognitively able, especially in public settings. You will see people who, literally the police are called. The police may haul somebody off in handcuffs without necessarily knowing. I think it was in Illinois a few years ago, they told me that the EMTs actually were using ketamine to sedate people when they had meltdowns in public. And they said, very safe, and I came back here and talked to the chairperson of anesthesia. I said, what do you think about that, Roberta? She said, geez, I wouldn't do it. But it's interesting. One of the things that we need to do a better job of is also training people like firemen, police, other folks to be more aware of what autism looks like when somebody's having a meltdown in public. And again, that leads us to thinking about, we have models for doing this. We have our own police project here. There are some attempts around the country now to provide specialty training for people like policemen, firefighters, EMTs, of what to do and what not to do. And again, if anybody's interested, I can give you some examples of problem situations. One is always surprised. Finally, in terms of legal issues, transitions are mandated under the law to be part of the planning process. You're supposed to be doing this, I think, starting around 15. The problem is you'll see all kinds of sort of ways that this is approached. Not uncommon for people to sort of give lip service and then not do much at all. Or to say, well, we'll put him here he'll volunteer at Walmart, or he'll be a greeter, or but non-meaningful things. And it really behooves us to think more proactively about what are good fits. There are some things that aren't going to be good fits. Selling used cars or vacuum cleaners or life insurance, not a good idea for a person on the autism spectrum. Computers, on the other hand, very rigid, rule-governed, repetitive, visual. Let's get something going for it. So it's thinking about that kind of thing that can be helpful. The health insurance issues are a worry. Happily, with the new mandates for providing coverage for children until they're 20-something years of age now, that's a plus. But it's not uncommon for us to, as children age into adulthood, they lose their parents' health insurance coverage. Maybe they're eligible for Medicaid, maybe not. But that's a real problem. And lots of issues in terms of variability from states, in terms of who's responsible, guardianship, estate planning, assumptions about siblings. I tell parents sometimes will assume the younger sibling is just going to take over the child's care. That may or may not be what the younger sibling is thinking. And you can only find out by talking to them about it. So things like that. Also, something, just giving money, not always so smart either. There was a classic case of a famous playwright in this state a few years ago who died and left a significant sum of money to his child who had Down syndrome and was in one of the state schools. And, of course, what happened? The state took the money. There's a big bill. So you have to be careful in terms of your estate planning. There are ways to think about special trust and other kinds of accommodations, but you have to have a good lawyer to help you. More and more people are entering the workforce. We've moved from what used to be the kind of sheltered employment model, which was really make work, to things that now we have supported employment more and more for people, and many people who are truly independent. These are people who can be wonderful workers. I've given the example, the man who did the copying business for me is very consistent. He's here, rain or shine, it could be a blizzard out. He walked from across town to get here on a day when there's this horrible blizzard, as did our then speech pathologist from Massachusetts who drove down all the way in the horrible blizzard. I had a fellow who lived across the street in the apartments that couldn't come. So there are some pluses. On the other hand, there are some issues too, and I've given you some examples we can talk about more, but I want to save some time for questions. Living arrangements, group homes, supported living, independent living. There's all kinds of pros and cons. This is an interesting thing. There are more and more transitional programs available, especially for the more able people, a growing population around the country, which gets us into thinking about colleges and vocational schools. College is a different business than public school education. Under Public Law 94-142, you are entitled to a free and appropriate education up through high school. College is not a right under the law. College is a privilege. Now, there is a different law, the Americans with Disabilities Act, that applies in colleges, that mandates services for people with disabilities. It's a different business. You can get kicked out of college very easily, and our kids do. And it's often around sexual stuff, which is unintended. People will come up and make a very explicit request, and you have to say, no, you cannot ask. There's many rules about how you go to bed with a girl, and let's talk about, there's 5,000 rules, right? And the person wants to, as it were, sort of go to home plate directly, and will ask make a very explicit sexual request, and can't understand, because he's very polite, what the problem is. Academic skills can loom very large. There are a number now of transitional programs. We have one here that we've been working with, the autism class that Jamie and I do during the year for Yale College students. The students work both at Benhaven, which is a school for generally lower functioning people, and there's a program at Chapel Haven for the more cognitively able who are learning about being independent and being able to go to college. And again, it's and there's maybe 15 of these programs now around the country. It's fantastic. We clearly need more emphasis on research-based treatments. We need to translate results from research into practical applications. I mentioned the internet. One of the problems for parents is getting quality information. We have tried to do more and more in terms of just that. And again, for parents, we want to provide quality and understandable information on the YouTube site, on the internet. If you go to YouTube, type in Yale and Autism, up will pop a series of 15 lectures. This was funded for us by some of the associates. It's the lectures from our autism class. It's things like genetics, communication, infants with autism, and it's free and available in 50 languages. I had somebody last year in Sicily come up to me from, I think it was Uzbekistan, to say she'd seen my lecture on autism. That's fantastic. And again, it's out there, it's free, and we hope it's quality, but for God's sake, whatever else true is, it's Yale College. There's a lot of misinformation, unfortunately. The number of treatments that come out for autism, it's also like the flowers in spring. It's just amazing, often with minimal empirical basis, and sometimes posing risks to the child and family. Helping parents become aware of complementary and alternative medications, medical interventions is important. Again, by definition, if it's complementary and alternative, there's not an evidence base, or there's not a substantive evidence base. So that's a dilemma. And I think in general, my experience is the pediatricians vastly underestimate the percent of parents who are using complementary alternative treatments because the parents get the vibe that they don't want to talk about it. As a psychiatrist, I want to talk about anything. And so I think we typically hear about 90% of the younger parents of younger children are using some kind of complementary and alternative treatment. And helping parents be informed consumers and advocates is really important. I want to end by just talking about some of the advances here. We have started some new services, clinical programs for adolescents, young adults. We're trying to get up and running in terms of a college planning service. We're expanding things in Madison. We have some new research initiatives. I mentioned the new fellowship program we have for adolescents and adults, and we're trying to do more in terms of outreach. So in summary, there have been many advances. This is a very exciting time. There are issues in terms of where we need to translate our research into effective practice and developing models of care for adolescents and young adults that could be equally as effective as they are for younger children. Let me stop there, and we have a few minutes for questions.